Good evening, everyone. Now I invite the joint interactive case discussion, and I would request our panelists, Dr. Sargent, Dr. Karthik, Dr. Frank Kanziora, Dr. Wolf Lillingquist, and Dr. Peter Wakzoke. Are you all there? I can see most of them. And without much delay, I would request Professor Wolf Lillingquist to share his screen on the case of osteosarcoma of the chest wall with spinal involvement. Incidentally, many years ago in 1999, I did a short fellowship with Professor Lillingquist, and I was really impressed by his work. And I would be happy to see this case and take it further.
Ladies and gentlemen, dear colleagues, it's a great pleasure and honor for me to present a challenging case of a primary malignant tumor of the chest wall and the spine. And I would like to take you through that case, and we have a one-year follow-up as well. This was a 18-year-old patient, a male patient, a lumberjack, a forestry worker, with the osteosarcoma of the fifth rib. He had a CT-guided biopsy in October 2018, and he received 2 cycles of chemotherapy, and we were contacted in February 2019. And these were the CT scans pre-chemotherapy. You see the large, extensive tumor mass with affection of the rib and close proximity to the vertebral body. And this was a shrinkage of the tumor just after 2 cycles of chemotherapy. The MRI scan reveals the huge size of the tumor, both in the frontal and the actual planes. With here you can tell the affection of the involvement of the vertebral body and the neuroforamen. So the big question here is will you be able to achieve clear margins by cutting through here somewhere, or do you have to take out the whole vertebral body to be safe? Again, after 2 cycles of chemotherapy, the tumor shrinked to this size, as you can see here. But also note here the close proximity of the tumor to the neighboring upper and lower rib. Some further details are the following: a close proximity of the soft tissue mass to the aorta, and a potential infiltration of the lung, as you can see here. Surgical planning. Is a partial vertebral resection sufficient? Will that guarantee clear margins? Or should you perform an en bloc resection on the vertebral body to be on the safe side? How many ribs should you resect? Just the one, or should you resect the neighboring upper and lower rib? Which approach? Only posterior, posterior anterior, and how do you cover the chest wall? What about the lung? What about the aorta? And bear in mind, this is the osteosarcoma. This is a highly lethal disease. If you as a surgeon don't achieve clear margins, the patient will have very, very low chances to survive. So free margins are mandatory. And you have to get it right from the beginning. Here again are the pre-op, and I like to look at the pre-chemo CT scans and MRIs because they help you deciding upon the extent of your resection. We opted for a en bloc spondylectomy. I personally thought that would be clearly the safest choice. These are the levels that we resect: 3 ribs and 2 vertebral bodies, with the sacrifice of the nerve roots T4 and 5 on the left side, with posterior fixation T2 to T7 and reconstruction of the chest wall with the Gore-Tex patch. We did a T-shaped skin incision in order to be able to, you can tell here, to laterally osteotomize the ribs. We did, of course, here the pedicle screw instrumentation. We did all the release. We encountered a heavy epidural bleeding and very strong trunk muscles. So it was quite a tough surgery. And after having created a free corridor and done all the posterior work, including the rods. We put the patient on the right side and did high left-sided thoracotomy. Fortunately, we did not find any lung adhesions. We asked the vascular surgeon to liberate the aorta, which was a good idea. So you get a bit of rest as a surgeon. And then we completed scectomies and reconstructed the anterior column with this titanium vertebral body replacement. And nowadays, I slightly changed my technique. Nowadays, I would use a carbon fiber reinforced PEEK cage for that. And this is a resected specimen after 10 hours of surgery, 3 ribs with a tumor here and 2 vertebral bodies. The chest was reconstructed with a Gore-Tex patch, and total blood loss was 3.5 liters, and the OR time was 10 hours. So that was an all-day surgery. He was put on quite a prolonged ventilation for 5 days due to a severe post-op bronchopneumonia, and he stayed even for 9 days in ICU just for pain control. But then he recovered very swiftly, and we were able to send him home after 14 days. But here's the histology report, which is very important. Number 1, free margins. Number 2, full response to the chemotherapy, which means the pathologist could not find any vital tumor cells in the resected specimen. And these are very, very good news, because with these 2 results, free margins and full response to chemotherapy, this patient have a chance of surviving that disease of more than 90%. We sent him home after 14 days. These are post-op X-rays. And here's the clinical picture. You can tell from his muscles, he was a very strong young man, that this was quite a challenge to get through all this chest wall muscles and do the resection. But the wound healed primarily, and he was up and about and was fit to go home after 14 days. We have a 1-year follow-up. There was no evidence of disease. He completed his cycles of chemotherapy. He's now again full-time working as a lumberjack, and he sent me just this picture, happy young man. And these are the CT scans and the X-rays after 1 year. Yes, discussion of osteosarcoma. Free margins are mandatory for survival. Again, a meticulous preoperative planning is necessary, and an interdisciplinary approach. You have to have a close collaboration with oncologists. You have to discuss all the X-rays and images with your radiologist to make sure how to do that surgery. Never go unprepared into theater if you have such a case on the list. And survival rates, and these are again older literature, I would say, 6.7 years or 5-year survival, 20 to 60%. My personal experience is that if you have full response to chemotherapy and free margins, they have a high chance of surviving the tumor in osteosarcoma and in neurosarcoma patients, probably more than 90%. So thank you for your attention. I hope you enjoyed that case, and I look forward to a vivid and extensive discussion. Thank you, and best greetings from Germany.
Thank you, Professor Lillenquist. That was a brilliant case and very exciting one as well. I think we can take some questions on this case, and any questions from the panelists? Dr. Rajshekharan, Dr. Venkatesh, Dr. Gautam.
Wolf, may I ask you? So one of the critical points in this case is that you decided to take out the 2 vertebral bodies. Why did you not decide for a split? If I look at the first MRI, I would say that might have been possible as well.
It's just to be. I take that point very well, and I discussed that with my partners. But the thing was to be as safe as possible in terms of margins, in terms of neurology, because if you have to split that third of the vertebral body, you have to quite mobilize the spinal cord up there in the upper thoracic spine. And number 3, how do you make sure that you end up with the resection appropriate and doesn't endanger the aorta in the anterior part? So since there was hardly any soft tissue involvement of the vertebral body, it was quite easy to take down those 2 vertebral bodies. And at the end, I am very happy that I took that decision. I believe this was the best way to solve this problem. I'm not saying that the other way around, it might have been possible too, but in my hands, I thought that's the best option.
There's a question from Dr. Jaiswal. Professor Jaiswal, please. And then Dr. Marcus.
Actually, I was going to ask the same question. Why did you sacrifice the other part of the vertebra? The next question was when you release the opposite side, the non-tumor side of the vertebral body, do you release it from the ribs or from the costo-transverse junction if that is intact?
I resect.
Number one. And number two question, do you routinely do embolization of these tumors before going in for surgery?
No. Since we stay out of the tumor, we don't need to embolize them. We do no embolization. And question number one is, this was a left-sided tumor, so you have to do all the right release on the right side from the back. So you cut the ribs close at their necks and leave the heads on the resected specimen. And then you do all the anterolateral release from the back, which is very important because when the patient's once lying on the right side, you have no chance of accessing the right side when doing an left-sided approach. So you have to do all that release from the back.
No, my question was this on the right side where the normal ribs are there. The right half of the vertebral body was all right. So do you have to sacrifice a portion of the ribs on the right side? Or,
yes.
Or you can get away with just doing at the costo-transverse junction?
You have to cut the ribs on the right side at their necks in order to be able to, or you can even, I'm not sure you might also just mobilize the rib head from the vertebral bodies. That might be another option. But anyway, you have to disengage the ribs from the vertebral bodies, of course. And you do that from the posterior approach.
Yeah, thank you.
Marcus? Yes, Dr. Marcus.
Hi, Wolf. You had a perfect responding concerning the neoadjuvant therapy. If you would have known this before the resection, would you have to done the same resection? And second question would be, I haven't seen a PET CT at the first time of evaluation, because there you could have seen exactly where the active margins of the tumor would be. That might help sometimes to decide for the procedure a little bit. What do you think?
Yeah, well, thank you very much, Marcus. Question number one, yes. I mean, don't mess around with osteosarcoma patients. They have a very high mortality. We all know from the former days, they all died, even though you resected the legs in these patients. So still the mortality is very high in these cases. So we go for really full surgical control and free margins. I mean, just go back to the extremities. You always would go for wide margins. Wide margins is 2 centimeters extra the capsule, which is hardly possible in the spine. So if you take the Anakin rules from the extremities and refer them to the spine, I think that was the right decision to take. And yes, we had a PET CT. We had all pre-op workout. The patient came from one of the large university hospitals from the south of Germany with all the pre-op workup, just came for surgery to Münster.
If there are no more questions, shall we move on to the next case discussion? It's giant cell calcified thoracic disc herniation, a complicated problem. Professor Peter, please.
Chairman, ladies and gentlemen, so as a follow-up of my presentation on thoracic disc herniations, I would like now to present a challenging case where we have treated a patient with a thoracic disc herniation and not everything went as expected. And I would like to also pose some questions to the auditorium, and you can think about how you would have decided in the individual situations. So the patient that I would like to present to you is a 60-year-old male patient who presented initially not to us but to an outside institution with pain in his mid-thoracic spine and radicular pain approximately around T6. Then the patient deteriorated slowly, first developing slight weakness of his left leg and bladder dysfunction, and then he showed to have a calcified large disc herniation in the mid-thoracic area. and he presented to this outside institution in August 2019. These are the images the patient obtained at that time. It shows the large calcified disc at the mid-thoracic level at T6 and T7, which can be identified over more than one axial section. And in addition, the CT nicely shows the disc herniation, which is really centered in the midline and is of large size and is completely calcified. So it has been a very challenging case for a very severe patient presenting with a very severe neurological deficit. So the surgery was performed immediately at the same institution, and the laminectomy was performed over 2 levels. And the surgical team has performed the intraoperative neurophysiology, and immediately following the removal of the 2 lamina, the patient went into spinal shock and had a bilateral loss of the motor evoked potentials. And this was confirmed postoperatively when the patient presented with a complete motor loss in both of his legs. And unfortunately, the disc was not removed since the surgery was stopped as soon as the patient had deteriorated by a neurophysiological means. The patient first then did not recover, and he underwent intense rehabilitation and slowly showed some improvement. We saw the patient exactly 1 year later in August last year, and by that time the patient had improved and he had a paraparesis with a strength of 3 out of 5 in the left leg and 4 out of 5 in the right leg. He was able to walk a few steps with assistance, and he had also developed severe neuropathic pain, which gave him strong discomfort, especially at night in the left leg. He was able to walk a few steps on his own without assistance, and with assistance a little bit better. These were the images that we had obtained in our institution. You can appreciate the area of the laminectomy in the CT. It's a 2-level laminectomy, and you can also appreciate that the disc is still in its place. It's still the same size, the same calcification, and it's still localized in the center of the spinal canal. And now this is really a very challenging situation. The patient has severe neurological deficits, and the patient had been operated previously, and these are the 2 major determinants, or the 2 unfavorable prognostic variables for the future treatment of this patient. And this brings me to my first question to the auditorium. How would you have decided? What would you have recommended? Number 1, do nothing and continue to rehabilitate because surgery might be too risky. Number 2, treat the pain, which is really affecting the patient a lot, with neuromodulation. 3 would have been to readdress the disc herniation by a more posterolateral approach. That means come again through the same skin incision, but now more lateral approach. 4 would be to readdress the disc herniation with a transthoracic approach, so a complete change of the approach and of the concept, or simply perform a posterolateral fusion without readdressing the disc. I will give you a few minutes to think about your answers and think about what you would have done. So we decided to go for option 4. The idea was to readdress the disc through a transthoracic approach, and we performed the surgery in September of last year. We have performed the transthoracic retropleural approach with a mini thoracotomy on the left side. You can see here the intraoperative CT that we have used for our fully navigated approach. We have identified the level, we planned the extent of bony resection and the surgical strategy to push the disc fragment into the cavity that we would have created with our high-speed drill using a microscopic strategy. We have performed electrophysiological monitoring during the surgery, and everything went well. The electrophysiology was uneventful this time, but when we were mobilizing the disc into the cavity, we realized that the calcified disc was strongly adherent to the dura, and mobilizing the disc resulted in a dural perforation and CSF leak and we directly faced the spinal cord after removal of the posterior ligament and the disc herniation. They were completely removed, the disc herniations and the posterior ligament at this level, and then we had to patch, glue, and we inserted a lumbar drain. Patient was first doing well, but 6 hours later he was developing a complete motor loss in both of his legs. He was completely paraplegic. We have performed an imaging which shows a good decompression, bony decompression, but we could identify a postoperative hemorrhage, or this was the patch that we had placed for taking care of the dural leak. So we immediately revised the patient through the same surgical approach, and postoperatively the patient was again paraplegic. The patient was admitted to the ICU. We kept the mean arterial blood pressure is 85/90 millimeters mercury. We performed a therapeutic transcranial magnetic stimulation in order to increase the brain plasticity, and we were lucky. The patient improved after 7 days to an acceptable level. 3 out of 5 in his right leg, 2 out of 5 in his left leg. And interestingly enough, the pain, the chronic pain, had gone completely. We performed a chest x-ray, which was okay, and removed the lumbar drain. We were able to start a mobilization of the patient and treated the patient by physiotherapy. But then the patient developed a respiratory insufficiency. You can see the chest x-ray showing the effusions. He had a effusion of 1,500 mils, 1.5 liter into his chest, which was punctured and which revealed CSF. And obviously we had a CSF leak which was draining CSF into the thoracic area as a result of the dural tear. And obviously our patching was not sufficient. So what now? We have a dural tear. We have a patient that was treated surgically 2 times meanwhile. He 2 times deteriorated surgically. And now I would like to ask you, what would you do next? Would you repeat the chest drains and avoid the surgery? Would you reinsert the lumbar drain and avoid surgery and hope for a spontaneous closure of the CSF leak? Would you address the dural leak through the old or the most recent thoracotomy approach? Or would you address the dural leak now with a posterior approach? And then obviously the prevalent question, how about fusion? So now that we are readdressing the patient again surgically, should we now perform a fusion? Since we have removed quite a lot of bone, there's the laminectomy and the facet joints have been removed. So again, I would like to give you a few seconds to think about your answer. So we felt that the fusion would be indicated, and the idea about the fusion was really driving our approach. So since we were thinking about fusion, we opted for the posterior approach, and the idea was to close the dural leak coming from a posterior approach and opening the dura and taking a transdural approach, as I've shown you, as it has been described for removing some of these discs. So we went for a transdural approach. We opened the posterior dura, we cut the dentate ligament, we rotated the spinal cord, and then we sutured the dural leak, and we patched the dural leak using an inside-out approach. So midline approach, removal of the epidural scar, handling of the dura and of the spinal cord. We could confirm that there was no mass effect by our muscle patch. We closed the holes, and interestingly enough, we identified a second hole, which was only due to the transdural approach. We could suture both of these holes, and then we placed the pedicle screws and we performed a posterolateral fusion. These are the postoperative controls, the X-ray and the intraoperative CT, pedicle screws in place. You can again appreciate the extent of bony resection and the removal of the calcified disc. The postoperative course was hard. There was no CSF leak anymore. That was the good news. However, the neurological deficits were initially unchanged. There was no pain, and we could discharge the patient to rehabilitation. where he continued to improve. Meanwhile, he's able to walk with some assistance, but longer distances, so he is clearly making significant progress, and his thoracic imaging shows that there is no CSF leak and that the closure of the dural leak has been successful. So looking back on the course of this patient, a critical analysis of this case would number one, in our eyes, show that the transthoracic approach was appropriate. I think it was important to change our approach and to remove this disc herniation, not through a posterior but through a transthoracic approach. The transdural approach, however, showed to be very sufficient for exploring the dura, and we have learned from this that the transdural approach is not only ideal for removing soft discs but also taking care of CSF leaks or perforations of the dura as a consequence of lateral approaches. We always believed that the fusion was mandatory, but we were waiting whether we would have to come back in order to take care of the dura. But critically, we have to admit that the dural hole should have been addressed immediately. By losing the CSF and by losing this kind of buffer, we believe that the spinal cord was prone to additional injury. And as a lesson learned from this case, we would now consider taking care of the CSF leak immediately, because the CSF leak is obviously a risk factor for myelopathy and for neurological aggravation, and therefore we should have closed the transthoracic approach, changed the position of the patient, and come in from a transdural posterior approach and take care of the dura immediately. And maybe this would have avoided the initial decline following our transthoracic approach. Thank you very much for your attention.
Thank you, Dr. Peter.
Shankar, can I make a comment?
Yeah, sure.
Peter, this was a fantastic case. In true perspective, the issues with thoracic discs, and of course, the posterior approaches of decompression are definitely contraindicated. My question is, as we do for cervical myelopathy nowadays, we don't go to remove the entire bone in the front, but deliver it into the, decompress indirectly by delivering it towards the front. Would that be an option rather than try to remove that calcific fragment, just deliver it anteriorly and leave it there?
You mean to say a floating piece?
Yes.
That's an interesting point, because I mean, what you do is you create the cavity as I've shown, and then you deliver the disc and the calcified posterior ligament into this defect. And now you are asking whether it makes a difference to pull it out or to leave it there. In the end, it's a loose fragment, and I would be maybe afraid that it might jump back or might dislocate from there. And I don't really see a disadvantage of removing it. So also from a lateral aspect, different from the anterior aspect in cervical disc surgery, it's always a little bit difficult to assess whether you have a complete decompression of the spinal cord. So while I'm thinking about your suggestion, I would go rather for the conservative way and remove it. But I think the idea that you are saying to leave it there is something I should think about in the future, yes.
Dr. Peter, there's a question from the audience from Dr. Kitish Chaudhary, which says that if you use non-invasive positive pressure ventilation in CSF leaks which have gone into the chest, the CSF leak apparently resolves on its own. What's your views about that?
Oh, the patient was spontaneously breathing, so it's...
But we give a BiPAP or a CPAP, and apparently with the CSF leaks do close over a period of time if you continue with this BiPAP or CPAP for at least 4 5 days.
I see. You mean a non-invasive increase in pressure. Okay. Yeah, but for the first 7 days he was doing fine. So we would have expected that that by trying again on a conservative way. So number one, we would have expected by trying in a conservative way, it would not close after 7 days. maybe the patch has dislodged and the dura leaks open because there was nothing. The problem is you remove the bone and there's nothing that holds your graft in place. Number two is we anyways thought that we will have to come back for fusion. So we were quite open for readdressing the dural leak from a posterior approach. And number three is that we found a second hole, which we had not patched. And I don't really see that this would close spontaneously just by changing the pressure. And then obviously it's difficult for managing the patient that was a little bit adipose and a little bit impatient with his situation.
Superb case.
Shankar, I think Dr. Srivastav has a question.
Yes, Dr. Srivastav.
No, I just wanted to say all this calcified or ossified disc, which is central, we have been doing regularly from posterior side. Not a big number, but we have been doing the internal gibectomy. The similar way, I have taken out these calcified discs by tilting the table, taking out the part of the rib, going posterolateral acute angle, burying out the body and taking out the thing. But of course, from the beginning, we have been fixing and fusing that level. And that is the reason I asked question in his last presentation, why did not you fix and fuse that level?
Yeah. So from literature that I've shown you, the lateral or posterolateral approaches are also successful with a acceptable morbidity. We feel they are more invasive, and we are more familiar, or we prefer the transthoracic minimally invasive approach. Given that this patient needed fusion because his facet joints had been removed, I would agree to you that maybe this kind of approach would have had his advantages. However, we felt that the disc is huge. The patient had neurological injury before, so we wanted to go the safe way. And I feel the safest way is coming from a retropleural approach. But your point is well taken, given the whole story of this specific patient.
Thank you, Dr. Peter, for that wonderful case, which evokes so much responses. Our timekeepers, Dr. Dillon, says that we are 7 minutes late, and I request Ram to invite our speakers next.
Thank you. Thank you so much, Shankar. It's been a pleasure. The first two cases by Professor Lillenquist, with whom, just like Shankar, I also visited his center about 2 decades back at Münster, and it was a great pleasure being with him. And Professor Peter Walkowski, it's been a great pleasure listening to these very challenging situations. One of a kind, we've learned a lot. And we now have 2 Indian experiences, both from the city of Chennai in southern India. May I first invite Dr. Karthik Kailash, a senior spine surgeon from Chennai, to share his experience on post-traumatic, post-surgical thoracolumbar kyphosis. Dr. Karthik Kailash, may we please see your slides?
Karthik, are you there?
Yeah, I'm very much here.
Please share your screen. Lovely. That's great. Full screen. Thank you so much.
Okay, thank you at the outset to give me an opportunity, and thanks to interact with the Wolf and all the people here. Now, this is a very interesting thing here. And 13-year-old girl with a history of fall from the first floor many years ago sustained this injury. And of course, I don't think there's going to be a debate on whether we have to do anything for this. We have to operate. So one of my colleagues, unfortunately, decided that he's going to do this procedure. Okay. Now, what would be your comments? Can I ask some comments and then 1 or 2 and then go on, or should I just finish off with that? Shankar, Ram? Shankar, Ram, could I ask?
Yes, if there are some instant answers, we could take a comment, but
yeah.
obviously. Yeah.
So this is what somebody has done, one of my colleagues done at that point of time. So what is the next thing which somebody would like to do for this?
I think Sarjan wants to say something. Sarjan, can you unmute yourself?
We have moved a long way from these kind of fixations and all that. So there's no point in beating the same old drum. I think, of course, you would. Now, what is the problem that the child has, I mean, now maybe a woman, what's she come for?
Well, I will come to that in a few minutes. She's got severe pain in the back.
Well, that is evident. So she is mainly having pain of instability.
Right.
So then things are very straightforward, I would think.
Fair enough. So we will all look at in terms of revising this and going posterior. Now, my friend decided that he's going to do something different. So this is what somebody has done. And unfortunately, as Gautam would describe in some meetings, surgical terrorism. So this was done, and this poor patient was led to follow up, saying everything will be all right, and finally landed up on the middle picture with a deformity, with implants both anteriorly and posteriorly, severe pain and kyphosis, not able to even sit properly. So what are the options now?
Karthik, the options are the same. Only thing is, it is a more of a challenge. The options are the same that need to be done to correct the deformity from the front and back. But what has been done, you're right in calling it surgical terrorism.
Okay. So without much ado then, as Sergeant very rightly said, our aim would be to get sagittal balance, solid arthrodesis, and to revise the whole thing. So our technique was go in posterior. It's a 3-stage procedure. Go in posterior, remove the heart shield rectangle, the wires, do an osteotomy, pedicle screw insertion, and then go ahead, do an anterior. The difficulty in the anterior was because the cervical plate was put in, the whole thing had bent in, and the L1 and L2 was one on top of the other, and the visualization itself was not there. So we had to do an osteotomy there and a correction there, and then go back in and do a posterior corrective surgery and complete the osteotomy from behind in a 3-stage procedure, all done in one single sitting. The final result, immediate post-op, where you could see that some reasonable balance has been obtained. And now, to my pleasant surprise, this girl is now working in the World Bank as an IT person. She came back about 15 years post-op to show she's completely fused, no pain, and she is now wheelchair to ambulant with HKFO, gaiters, etc. So with this, I would look at some comments from my colleagues, and I wish to say well done ASSICON with this video, as they demonstrated this wonderful teamwork.
Salute Bourbon.
Well done to our team. Thank you very much.
Thank you, Karthik. That's an excellent presentation. Now we are open for discussion. Any comments, Sergeant, first from you, because you have already had a first bite at the bullet. Go ahead.
What do you want me to say, Ram?
Okay. Then we have Shankar. Any comments?
I don't want to say too much.
You're on air.
I don't want to say too much.
Yeah, I think this case was, as both Karthik and Sergeant said, is surgical terrorism. Everything, all these principles were violated. But obviously, this case was done many years ago and long time ago when we were doing heart shield for spinal fractures. Obviously, the principles of heart shields were not also adhered to, and you need multi-level fixation when you do sublaminar wiring, and you need to get surgical reduction. So obviously, all the principles were violated. And then somebody put a H plate or some sort of a 3.5 plate system anteriorly with multiple small 3.5 screws. So that obviously also was a failure in toto. And I think let's not discuss too much about the surgery that was done, but obviously I think Karthik did a good salvage procedure, and I'm glad to know that she is now wheelchair to and she's able to mobilize with gaiters.
if there are no more comments, maybe move on to the next case, or would the faculty like to say something on this case?
So can I make a small comment, Dr. Ram?
Please, Dr. Basu, please.
So was it an option, Karthik, very well done, but was it an option not to go anteriorly and do it entirely posteriorly? Because I feel that these 3.5 millimeter Casper plate, whatever was put on, did not have any hold on the bones. So if you approach it from the back like a VCR approach, go in bipedicularly, take out both pedicles and do an osteotomy from the back as is done for kyphosis correction, for rigid kyphosis correction, would it, could you have solved the entire issue posteriorly? Was removal of the anterior implants necessary?
Well, I see the L1 was completely under the L2, and I couldn't even visualize it anteriorly. And so it made things much more difficult even then. So I think going posteriorly, and then this is way back in 2001, when osteotomies and all that were not very proficient. So I was not very proficient in that part of it. And then I think, for me, in my hands, I thought going anterior, taking the whole thing out and doing it in a 3-stage was a better choice for me.
At the end of the day, the deformity was not very sort of radically corrected, neither was it necessary. So if you could just leave if just did an in situ up-down fusion, strong posterolateral fusion, would it have solved the issue? Just take out the posterior implants, go long up, long down, do a very well posterolateral spinal fusion, because it did not do a laminectomy also. That would have stabilized her, and maybe that the fusion would have occurred.
I don't know. I mean, this is a thought process which we went through. Maybe if I had the same case now, I'd have gone all posterior or something different. So
Basu, I think there is something that is your answer, there is something that is my answer,
yes,
and there is something which is a correct answer, which is somewhere in between. So we all learn from each other. So thank you very much, Karthik, for an excellent presentation. May we move ahead
from the German delegation as to how they would deal with it at this stage, not at the earlier stage. Whatever is done is done.
Would Professor Lillenquist and the entire German team have any comments, sir? Wolf, any comments from you? Marcus, Peter?
Well, I think, do you hear me?
Yes, loud and clear. Please go ahead.
Yeah, well, I think everything has been said, actually. Now, the first, there was no reduction. There was, well, not implication of the biomechanics of the spine, of the biomechanics of fixation. I think it's a very good case to see how you won't achieve your goals concerning reduction and stabilization. So very good case. Thank you for presentation.
Thank you, guys. Thank you for being very polite. Thank you very much. We appreciate. So we would now invite the most polite spine surgeon from our country, Dr. Sarjan Hegde, who's the most aggressive as far as deformities are concerned. And I'll invite Sarjan to speak on spinal deformity. Is it time to turn the page on tradition?
Ram,
Sarjan, all yours.
Ram, in this, I want to say I am being very much less aggressive than my normal behavior. And I want to put a new concept. So I'm going to take a little liberty, show 3 cases, but quickly, and stick to the time and make like a small presentation. So
all yours, Sarjan. Please go ahead.
So the question I'm asking is it time to turn the page on tradition? Okay, how do we? So for the last 100 years, we have been fusing the spine for instability and deformity. And for the last over 60 years, we have added metal implants to hold the spine in the corrected position till it fuses. Of course, we know that the gold standard was the Harrington for a long time. But since the 90s, there has been an aggressive move to favor posterior surgery, and is accepted as standard of care, like, for example, in this Lenke 5CN, where you see there is some degree of flexibility. And This is what I want to use, the term regional iatrogenic ankylosis for a shorter or a longer area of the spine has given extremely predictable results for us. Now, an old fogey like me, Arvind is also there. For a surgeon like me, the early years spent in aggressive management of tuberculosis of the spine laid the foundation for a high level of comfort with anterior spine surgery. And we were able to use that technique for our tubercular spines and put grafts and later on implants. As we are now with the German Society, I would like to thank my mentor, Professor Jürgen Harms, who trained me on anterior correction of deformed spine and its advantages. So I continued to use this technique right for a problem like this boy from Nigeria with a Lenke 4CN. Here you can see that the spine is very severely deformed, 86 degrees, the main deformity, and a counter curve above as well as a counter curve below. Now, posterior surgery would have meant D2 to L4, thoracoplasty, PSOs, blood loss over 1,500 ml. However, we have done a correction of the main thoracic deformity and let the lumbar spine correct spontaneously as well as the upper thoracic spine. So I continue to prefer using this despite an almost exclusive shift to posterior surgery in most centers. And here I come to these deformities like the Lenke 5CN, which to me today, doing a standard posterior fusion surgery, or for this one on the right side, a double curve, doesn't seem to be a very acceptable or satisfactory option. So here I want to talk about non-fusion anterior scoliosis surgery. Let me introduce a new technique which I think will turn the page on fossilized concepts. That is using a polyethylene terephthalate cord which is threaded through vertebral screws. The concept is not new. We used to do it when we were fusing the spine. So let us come to this child, 13-year-old, perimenarchal, Risser 0, Sanders 4. So in this child, do we just wait till she completes her growth and her deformity measures 60 or 70 degrees and then correct it with some degree of chest deformation? Do we brace her, or do we instrument her posteriorly straight away from L3 to D4? So this is an out-of-the-box non-fusion surgery which has been done. As you can see, some of the residual deformity still persists, and that is intentional. And at 2 years, you can see her spine is beautifully corrected, fully corrected through growth modulation. And as you can see on the right side, she has a beautiful position of her spine, a beautiful correction, and she looks very good. Now, this is a child we operated yesterday. I still don't have the images. Normally one would have done a D5, L5 to D2 instrumentation with the possible blood loss of 600 to 1,500 ml, or minimal invasive non-fusion correction, as you see here on the right, which we did yesterday, with a blood loss of less than 100 ml, and she can return to dancing, gymnastics, equestrian sports, as some of my patients have done after non-fusion surgery. And finally, to end, this little child who came to us from the Middle East, a 7.5-year-old child with a severe congenital deformity. Here you can see she has multiple congenital anomalies. The Cobb's angle of the thoracic spine is already 64 degrees. These are the CT scans showing the hemivertebrae at multiple levels. In 2019, just before corrective surgery, she was already severely decompensated. And an artist predicted that if left untreated in a couple of years, she would look like what she looks on the right side. What are the treatment options for her? Do we brace her? Do we serially cast her? Do we put growth rods with all the issues of visits, multiple visits to the OR, planned and unplanned, or do we do something out of the box? And we decided to just modulate her growth in the most deformed part of the spine. Here you see her pre-op and immediately post-op. Imagine this child was operated just before the pandemic. If I had put growth rods, they wouldn't have been able to come for a year and it would have been a disaster. The parents managed to send me a picture at a recent follow-up, 9 months, and you can see she's holding well. I'm not saying this is the end of the road for her. She may require surgery for the proximal spine, but maybe just one more surgery. For the moment, she seems very well balanced. Shoulders are balanced, and she seems to hold a correction well. Now, when we talk about adolescent idiopathic scoliosis, I think we'll have to move away from the Lenke classification. And here, maybe we will have a different classification as non-fusion scoliosis correction becomes more and more popular. I know in Germany, it is very, very popular. So the lumbar, thoracolumbar curves, the double curves, the long curves with the trunk shift, that's the ones that you may not want to do is those with, having a high thoracic curve. So maybe we'll have to have a different classification and maybe look at using this very new technique, exciting technique to correct our spinal deformities. But these are early days. The short-term results are extremely satisfactory. Of course, there can be a cord rupture, but the cord rupture can be addressed, for example, in the lumbar spine. We can do a double cord, which makes it a fairly expensive surgery. Alternatively, even if the cord ruptures, as Ahmed Alane from Turkey said, you may not need to revise. Unlike broken rods, which cause pain, a cord rupture may just add to the deformity, but may not need revision. Thank you.
Thank you very much, Sarjan. It's an evolving concept. And as you mentioned, Germany probably has embraced it. So we have the German Spine Society with us. Any inputs on Dr. Hegede's presentation?
I might comment on that.
Please, sir.
Well, thank you very much for highlighting the role of anterior approaches in deformity surgery. You're aware we have the Klaus Zielke, one of our teachers from our country. So I absolutely agree with you that there is a definite role of anterior surgery, especially in the thoracolumbar region, where you can frequently save vital fusion levels, especially in many cases from the back, you would have to go down to L4. And if you stay in the front, you can end with L3. Now, concerning this new technology of cords, well, we're on the very early phase. I would say it's still somewhat experimental. For the thoracolumbar region, I would be afraid of cord rupture and the curve sizes. In Germany, we have a long tradition of bracing. So those patients where in other countries, maybe a surgery might be an option, we would go for a brace. But we're watching those results very carefully, and of course, it would be great if it works to have a growth modulation and keep the mobility and go away from fusion. So thank you very much for your very wonderful talk and inspirations.
Thank you, Lundquist. I
Any other
remember,
comments?
when you were working with our good friend, the tall guy. What is
Henry
his
Harp.
Henry.
Henry.
Henry was the last fellow of Klaus Zielke.
Yes, yes, of course. It's a small world. Yes.
In fact, Lillenquist devised the smaller mini plate, and I remember that when that's when we were together. I remember that.
Yes, we have a long tradition of anterior surgery.
Yeah.
But in the thoracic spine, to be honest, I've more or less stopped doing anterior surgery, but I still do all the thoracolumbar cases. And every time I do from the front, it's always nice to see how well the correction goes.
Absolutely. Absolutely. Any other comments on Dr. Hegede's presentation? Dr. Jaiswal, please. Yep.
Sergeant has always a great presentation. I have a few doubts here, as I expressed earlier to you also. When the anterior tethers came into existence, they were not so refined as they are now. Harry Bess and Samdani's report. They were doing it for very early onset scoliosis. The type of indication that you use for your middle-aged girl, young, 4 or 5 years old, they had a lot of failure there because have a long span of growth left, So there were a lot of failures there, overgrowth and failures of tethers and things like that.
Sure.
So I think you did a great job initially to start with 12-year and 11-year, where the growth potential is less there. So you can wide time. So the results which are coming in with the newer tethers and the cords are for the elder, slightly older adolescent groups, right? And so the results are really good. So we need to watch and see what, number one, the results are going to be. As you likely said, these are short-term results are very satisfactory. I'd be a bit conservative with putting them on right away in very young, like early onset scoliosis, 4 and 5 year old, because they might land up into more problems there.
Any other comments? Dr. Hegde, any response?
No, I fully agree with Arvind. I fully concur with his feedback. But I look at it, for example, that child from the Middle East, what were my options? Doing a growth rod, requiring every 6 months a reoperation. The child has such small bones, such poorly formed bones proximally. The construct could always keep giving way. Also, we have seen a kyphosis developing above the level when we use the growth rod. I have had it, I have seen it personally. And all these things, issues that I faced with growth rods made me look at this option. But as Arvind says, these are early days. Some of us will have to come out clearly and tell where we should not use it or where we can use it and definitely give good results.
No, that's fine. You did a great job. I'm not criticizing that. But the question is, we need to have more evidence on this. And be careful. Watch this very young child, the 4-year, 5-year-old girl, as you go along, because revision of the cord would be difficult anteriorly when you go in again. Number one. And number two, if it fails at 7-8 years of age and it's progressing, then you'd be a bit reluctant to go ahead and fuse from the back. So keep your fingers crossed. Watch her very, very, very observantly. Thank you.
Which we are doing.
I think with that, Ram, we can close this session.
Absolutely.
And if I may have, and I thank all the speakers from the German Spine Society, and I thank the German Spine Society for, as Dr. Frank Kanziro said, that all the top-notch lines as the presidents, the past president and the future president and the president-elect are there. And it's a privilege for us really to be honored by your presence and that you have taken so much of your valuable time and we have learned so much. And it's always good to see Professor Lillenquist, with whom I trained 2 decades ago, as Ram said. I know he won't remember me, but I have fond memories of Munster, the cycle town. And I still remember he said, one day I take you out for dinner. I thought he will come out with a BMW. He took out his cycle and made me walk to the restaurant. So that is an amazing city. And thank you very much. With that, we can close this session if Gautam says so.